Morning everyone, and welcome to the very first webinar of the BA Online Week. Lovely to see so many familiar faces here with us. Just as a bit of an introduction, as we're waiting for a few more people to come online, throughout the presentation this morning, if you look on the panel on the right hand side of the screen, you should have the option to ask questions. So please do type away in there. We'll be asking Bill all the questions at the end of his presentation. You are all being recorded whilst we do this, so this webinar will be on demand in a members area of our website for the next 12 months or so. Also tomorrow, after you've hopefully not forgotten everything, you'll be sent an email survey. Please get back to us, let us know, because this is quite new to us. We'd love to know what you think of the webinar and BA Online itself. So right, I think we've got the majority of you here, so let's just do that. I am delighted this morning that we have a brace of professors joining us today, with our first one being Professor Bill Newman. He's a consultant clinical geneticist at the Manchester Centre for Genomic Medicine and Professor of Translational Genomic Medicine at the University of Manchester. Bill's research is focused on pharmacogenetics, and he is the chief investigator on a study that's just coming to the end, that's looking at implementing a point of care test to avoid hearing loss in neonates. So really important to all of us with NHSP and our follow-up of these babies as well. So I am delighted to hand over to Bill now. So sit back and enjoy. Type your questions in the question box, and I'll see you all at the end. Thank you.
Perfect. Okay, lovely. Thank you so much. And good morning to everybody. It's a real pleasure to join you for this BAA online seminar. My name's Bill Newman. As I've been introduced as a person who's interested in translational genomic medicine, and in genetics, as you know, we've been interested in discovery and identification of the genes that lead to a whole range of inherited health problems. And of course, hearing loss is a very important part of that. And we've been working on that alongside colleagues for a number of years. And there are a number of genes that you'll be aware of that leads to hearing loss, both early onset profound hearing loss, but also hearing loss associated with later onset and different degrees of that, both sensory neural hearing loss and conductive hearing loss, particularly associated with some conditions like osteogenesis imperfecta that might affect the bones within the ear. So discovery is clearly incredibly important and an important part of research, but one of the things that I find quite alarming is the fact that of all the research money that is spent, such a small percentage is spent on actually translating and implementing those discoveries into real clinical practice. And that is what I'm particularly interested in. There's an enormous amount of remarkable genetic data that is available to us, and it's deeply disappointing to me that it's not all translated into patient benefit as quickly as it could be. And that's something that I've tried to focus my work on, and hopefully my presentation this morning will demonstrate an example of that, and hopefully act as a bit of an exemplar where we'll be able to deliver more projects in this regard. And some of the learning points that we've established over the last couple of years particularly, I think will stand us in good stead to do that. So what I'd like to do today is talk to you about a new point of care genetic test that we've been developing and working with and using in the clinic to avoid gentamicin induced hearing loss, particularly in the neonatal setting. So this all started not with me, because I wasn't quite born at this time, but back in the 1950s, researchers around the world started looking at families with hearing loss and starting to draw out those pedigrees and look at the particular patterns of how hearing loss seemed to be inherited within those families. And that developed over the coming years. Molecular tests and ways of discovering the genes and genetic basis were still fairly rudimentary at that stage, certainly compared to what we've got available now. But there was the starting of trying to distinguish some of the genes that could lead to hearing loss. And there's a group of family trees that came to light that particularly seemed to follow a specific pattern. So rather than the hearing loss affecting just individuals within a single generation, so that would be more consistent with what we'd call an autosomal recessive condition, where you'd need 2 altered copies of a gene to be affected, or where every generation was affected, which would be consistent with an autosomal dominant pattern, or an X-linked pattern where just males would be affected. We saw an unusual pattern which was consistent with what we'd call matrilineal inheritance. So that is inheritance which is passed through the female line, such that where females are affected, all of their children would be either affected or at high risk of being affected. And where males were affected, that they would not pass the condition onto their children. And so this particular pattern was consistent with what we would call mitochondrial inheritance. So you'll all be aware that in every cell in our body, we have DNA in the nucleus, and you get half of that DNA from your mum and half of that DNA from your dad. And that's why we all look a bit like our mum and our dad, and why we've all got 2 copies pretty much of every gene. Well, in every cell, we also have these small energy bundles called mitochondria, and mitochondria are unusual in that they have their own DNA. It's a very small circular DNA package, but it's separate to all the other DNA that we inherit. And in each cell, we have hundreds of mitochondria, and mitochondria are important in the energy levels within the cells. And each mitochondria or DNA has about 37 genes, and they have a number of different functions, which we're starting to learn about in a bit more detail. So there was a group back in the early 1990s that started to look at some of these families in detail, and they started to do sequencing of the mitochondrial DNA. And in those families, they found that they could identify a specific genetic variant called the 1555A to G variant, which seemed to segregate or track with the hearing loss in these individuals. And it was noticeable that over the years that the individuals who most significantly affected within these families have been exposed to an aminoglycoside antibiotic. So often gentamicin, but any of the other antibiotics that fitted into this particular family. So just a small cartoon to demonstrate the function and how this, the mechanism about how this came around. So this is a cartoon of a bacterial cell, and within that you'll see that there is this mitochondria, and within the mitochondria there's an element called the ribosome. And the ribosome is where the proteins are made within the mitochondria, and you'll see that there is an element within the ribosome to what we call the 16S subunit, and it's to that particular subunit within the bacterial cell that the aminoglycoside, so let's say gentamicin, would bind, and it's through that mechanism that the bacterial cell is killed. So it's not only bacteria that have mitochondria, but certainly human cells, all human cells have mitochondria pretty much, And they also have this ribosomal subunit. It's slightly different in humans. It's a 12S subunit. And as you can see, it's got a slightly different shape. And so when the aminoglycoside is exposed to that cell, it doesn't bind and the cell remains completely healthy. And that's true of the vast majority of cells. However, 1 in 500 people have a different genetic change, this 155A to G, which means that the mitochondrial ribosomal subunit is changed in shape, and therefore the aminoglycoside can bind to that, and therefore the cells will be killed. And that is particularly true of very sensitive cells. And in this case, the inner hair cells of the ear are particularly sensitive to this effect. So 1 in 500 individuals will have a higher risk of developing hearing loss if they carry this genetic variant, if they're exposed to an aminoglycoside. And this is particularly true in neonates because, as you're all aware, and better than I am, that the hearing architecture is less mature in neonates, and therefore they are more sensitive to these effects. So that was first discovered in 1993 by Present et al. And over the subsequent years, genetic laboratories around the world have been able to undertake genetic testing for this particular variant. And that genetic testing has usually been done where an individual has got hearing loss and they've been exposed to gentamicin or another aminoglycoside, and the health professional wants to find an explanation for their hearing loss. And so it's after the event in some way that the majority of this testing is used to try to find an explanation for the hearing loss. One exception to that is where the testing is used in a preventative setting. So for example, children with cystic fibrosis or another form of bronchiectasis, where they would have recurrent chest infections, it would be very likely that at some point through their treatment journey that they would require an antibiotic like gentamicin, which is very effective against gram-negative infections. And so you would undertake genetic testing and see if the child had the normal or the variant genotype. If they're the normal genotype, you'd feel reassured that they could be prescribed gentamicin. Of course, you would need to check the levels. You wouldn't want to give them the antibiotic for any longer than they needed it because there are side effects out with this particular genetic change. But you could feel more reassured that you weren't exposing that child who had a high risk of hearing loss to an antibiotic where there may be an appropriate alternative. So in our laboratory and for other centres, routinely we would check children diagnosed with cystic fibrosis for this genetic variant. And that testing would take a few days, maybe a couple of weeks. You would have that information, it would go into the child's clinical record. So if it was ever needed in the future, you would have that information available to you in a preemptive prophylactic way. Now that's somewhat different to a situation where you would have a neonate, a newborn baby who may be at high risk of infection because they're so susceptible to infection at such a young age. So immediately post-birth, the NICE have introduced guidance that if you suspect a baby of being at risk or actually affected by infection, that you would treat them with an beta-lactam, so a form of penicillin, plus gentamicin, and that needs to be administered in the first hour of that baby being admitted to the special care baby unit or the neonatal intensive care unit, the NICU. So routinely, about 10% of all babies in the UK have an admission onto the neonatal unit. So that's about 100,000 babies a year, give or take. And the vast majority of those would be started on gentamicin and on penicillin. And so when the babies are admitted to the unit, what you would want to do is to gain venous access so that you could provide an intravenous infusion of these antibiotics. So as you can see, you have 100,000 babies who have been admitted and exposed to the antibiotic. And of those, if 1 in 500 carried the variant, potentially there are 200 babies every year who are at risk of having experiencing significant hearing loss. So, as I said to you, genetic testing generally took a couple of days to be able to be done. So in this context, if you took a sample from the baby as they arrived on the unit, you send that to the laboratory, you'd be waiting a couple of days, and that wouldn't give you a result when you needed, by NICE guidance, to give the antibiotics within the first hour of admission. And so what we needed to think about, was there a way of undertaking genetic testing that would give you a robust result, so you could be confident in that, that it could be done quickly enough, that it was cheap enough, and that people, parents, staff would be happy with to introduce into their routine clinical practice. So we've worked with a company based here in Manchester called GeneDrive, and have looked at what sort of technologies were available to develop a point of care test. So I won't go into huge detail, but to tell you that, as you'll know, PCR or polymerase chain reaction is a technique where you can make lots and lots of copies of a particular specific piece of DNA. And that's usually done by heating up the DNA to a very high temperature to separate it into its two strands. And then the enzyme allows, with the nucleotides, allows lots of copies of that specific bit of DNA that you have amplified up with, you've got particular primers to. So that's all good, but it needs a bit of time, and it needs recurrent cycles of heating, cooling down, heating up again to make the copies. And then you need a way to look at that of those multiple copies of DNA and see if the particular variant that you've got is there or not. So we initially developed a PCR-based test. We changed that to a new technology called LAMP, which it works on the same principle, but just doesn't need the same heating and cooling cycles quite in the same way as the PCR test does. Once you've made up all these copies, then what you are able to see is that a little probe that is specific for your genetic variant binds to the DNA, and that's got a little fluorescent tag sort of that lights up, and that separates from your DNA dependent on whether you've got the A variant there or the G variant there. So it's dependent on the temperature as to which it separates at. And you can measure that by running that through the machine, and dependent on which temperature the probe separates at, you get a signal at, and so you can differentiate between the variant and the wild type probe. And you can see that we could do this with a little machine which from the image fits in an individual's hand. So that was something that we worked on. We got a small grant from Action on Hearing Loss as a proof of principle to develop that assay just to see whether we could get that to work. We developed it so that we could, rather than needing a blood sample, we could take a swab from the cheek of the baby and see whether we could get enough DNA from a cheek swab to be able to do that. We changed from the PCR reaction to the LAMP reaction to try to reduce the amount of time it took. And eventually, after checking that against a number of both positive and negative controls, we were able to get that test down to work in about 25 minutes. So that seemed to us sort of in keeping with what you would need in a clinical setting so that you get your results back quickly enough. So we had that as our starting point. We had something in our hand which we felt could work in a clinical setting, but we still had a lot of work to do to actually prove that. And so we designed a study which we approached NIHR, their Eye for Eye program, which is a program which looks to academic and clinical groups to work with small companies to deliver an implementation piece of work to sort of really test something out in the clinical setting and to see whether the sort of intended use of the assay really worked. So it's fine and good in a laboratory like mine or the companies to test this and to say, oh yes, this works, it's absolutely fine. But would this test work at 3 o'clock in the morning where you've got a newborn baby and everyone's rushing around trying to make sure that everything's completely well with a baby who's sick, and with a nurse who doesn't have lots of training in genetics or training in running genetic tests? Could they one, do the test, and two, could they interpret the result of that? And then if they'd interpreted that result, would they then change clinical practice? So there were lots of things to try to establish in terms of whether this was going to be feasible or not. And so we got funding from NIHR to look into this in a bit more detail as part of the study called PALO, which is pharmacogenetics to avoid loss of hearing. So we started the study in June 2018 and split it into two parts. So year one was really about getting the protocol written, training all the staff that needed to deliver the program, trying to improve the assay to make that more robust and to speed it up. So that was partly when we introduced the LAMP process. But also the machine that we had used with GeneDrive, that hadn't been used in an NHS setting. And so we needed to link that up to make sure that it worked with having patient information plugged into it, and that it could give a result that could go into the patient record or could be printed out so that it could go into the paper record if that was required. And also we needed to know who had done the test and at what time and what day, and to get that information in case there were any problems. Year two was to actually run the assay on the clinical units, and so the plan was to do that both in Manchester and in Liverpool. One, because we know that each neonatal unit has a slightly different way of running things, slightly different processes. So a lot of the core things are the same, but there are different things that happen, and I can tell you a couple of examples around that where we've learned things by running the study in a couple of different places. But the idea is that we have a test at the end of it which is interoperable, which can work in any neonatal setting and in other healthcare settings. We weren't trying to design something that would only work in Manchester or in Liverpool. So as you can see, year one was about optimizing the device, and through the course of year one, we in discussion with the MHRA, ethical bodies, discovered that we needed, before we could start the study, to get full CE certification. So CE certification resulted in a lot of work to make sure that the test was absolutely robust, and we'd done all the negative and positive controls, looking at the test in different ways to check whether any things that could inhibit the assay had been looked at. So the test previously on this machine had all been done using adults, and so never really considered, could you get enough DNA from a baby? Would breast milk interfere with the assay? Could meconium or amniotic fluid, could that interfere with the assay? So we had to check all of those things. And as I said, we had to write out the protocol, get ethical approval, train up the nurses. I'll talk a little bit about those two steps in a second, and squeeze all of that into 1 year. And you know, year one, I must say, was really driven forward by a wonderful project manager called Rachel Mahood, who really sort of drove the project forward with a really wonderful team. And that's been one of the absolute joys of this project, that we've had a team of multiple individuals who are thanked right at the end, but have all contributed their own skills and knowledge in different ways into making sure that this project has progressed in the way it has. As I said, year two was around the implementation, and then we're just moving to now, as I'll talk about, the analysis and dissemination of the project, telling people how it's gone, what things have worked well, what things have been a bit more challenging that we need a little bit more data on, and what the next steps should be. So if you can imagine, when we were drawing out the protocol, here is our scenario. A mother is on the delivery suite. She gives birth to a baby. That baby is considered requiring a special care attention, and so is transferred to the baby unit. One of the challenges is that sometimes the mother, having just given birth, is not in a position to accompany her baby just at that time. And so that introduces a number of challenges, not only for the mother, but for the care team in looking after that baby, ensuring that that baby's best interests are completely paramount. At the time of admission, a number of swabs are currently taken, so they're just to check for any evidence of infection. And so what we were wanting to do was to add another swab, so a little cheek swab, the aminoglycoside swab, that the baby would have taken at the same time as their other swabs. And while the baby was having venous access secured and all the other things checked, like their weight, their temperature, what the major clinical issues were to stabilize them at that time, the nurse would begin the assay, and then hopefully a result would be available in the right time frame within the hour, and then the decision to either give gentamicin alongside penicillin would be given, or that the non-gentamicin pathway would be delivered. So this was something that was already in place in neonatal units. There are some babies that it's known that they've got significant kidney problems, for example, and that would be a contraindication to giving gentamicin. Or at least there'd be significant caution about that. And so there are already protocols in place what to do if a baby would require a different antibiotic to gentamicin, and so a cephalosporin would be used. And in fact, in a number of units around the country, we were aware, having done a survey, that the teams did not comply with NICE guidance because they were so concerned about gentamicin-induced hearing loss that they already were predominantly using a cephalosporin. So you could ask, well, why doesn't everyone just use cephalosporin rather than gentamicin? And the main reason behind that is because you can develop antibiotic resistance. And so gentamicin is a very effective and has a sort of narrower spectrum compared to cephalosporin, so it's less likely to develop resistance. And so that's why you'd want to continue using gentamicin if you could, and if you had the information that would allow you to prescribe that more safely. And so that's the sort of plan that we had set out that we were trying to establish. So here's the machine. You can see that we linked it up to an Android, sort of essentially a phone, so that you could type in the baby details, their name, their district or hospital number. It would be date stamped. That would be linked to the machine, which is on the right where you do the test. You can see at the bottom of the machine is the cartridge place where you just insert the little oh, sorry, I've got to just see if I can just stop that. I think I'm sharing a little icon on my, let me just get rid of that and then go back into, there we go. Okay, so let me just take you back through that slide. And so there's the, and on the left of the image is the printer, which would print out the results, but also print out a little label that we could attach to the sample so we could check everything was all consistent afterwards. And you can see that the results would come up that either the variant was detected with a red circle or not detected with a green circle with a very simple binary yes or no answer. Was the variant there or not? There wasn't additional interpretation that was required. So that's just showing that how we take that through and all the different steps that were required. So one of the things that we had to consider in some detail was that this was considered by the ethics committee to be a study in terms of a research study, because we were changing clinical practice. Now we felt that this in some ways was a service evaluation, that we were introducing a new element into clinical care that we would have done, because there was no clinical equipoise, if there'd been the technological ability to do so. So it wasn't a question of was there enough evidence that you would want this information or not, and that you would act on it. It was more that we just technically hadn't been able to do this. But because we were changing clinical practice, the ethics committee said that we needed to, one, register the project as research, and two, we needed to seek consent. So as you're aware, in accident and emergency, if a patient comes in with a myocardial infarction or with a stroke or a really serious healthcare problem, that actually obtaining consent from an individual in that setting can be really challenging, or in fact not possible at all, especially if you need to treat someone extremely quickly. At the same time, you need to put some checks and balances in place. And so the concept of securing prospective consent, where we would go through an information leaflet, give a mother time to consider whether she wanted her newborn baby to participate in the study, seemed to us extremely challenging, especially if the mother had just, one, she would have just given birth, but two, may have had an anaesthetic, may be undergoing procedures immediately post-delivery. Her baby's been whisked away to the neonatal unit, and she may not be accompanying the baby. And the antibiotic, we knew, needed to be given within an hour, according to NICE guidance. So was there truly time to secure prospective consent? We felt not. So an alternative would be to have undertaken the test, delivered the appropriate antibiotic, and then in the hours or days after that, to have gone back to the mother and sought retrospective consent. So we spoke with our patient support group, who was derived from mothers who had experience of looking after their babies through the neonatal unit, and individuals who had experienced hearing loss, and asked them about their attitudes towards retrospective consent, and then spoke to the nurses and doctors on the neonatal unit, and they said, well, actually, a lot of babies that come into the special care baby unit, they might be there just for a few hours before they're either discharged or before they are transferred to another centre. And so actually waiting a few hours afterwards is going to be quite logistically quite difficult. As you're aware, some of the parents, their babies may die in that time. And so going back to them and asking for consent to participate in a study where their child has died or is still undergoing really significant challenging clinical care could be really quite sensitive and quite difficult, and also maybe a distraction from the major issues that were important for the child and baby at that time. And so we explored an alternative approach, which is called opt-out consent. So this is a form of consent that had been considered by a number of groups looking at neonatal studies, where you need to do something very quickly. You would do the study at the particular intervention, and then afterwards you would ask by providing information in the packs of information provided to parents, inform about the study, why you were doing it, what it involved, and we had great help from our patient support group in designing this information so that it was informative but simple enough so that it didn't overwhelm. Unfortunately, we had to include all the GDPR information, so that was we got the actual information about the study down to one page. The GDPR guidance was 4 pages long, which didn't seem particularly helpful. But we sort of set out that we'd already done the test, that we were trying to find out whether this test would provide us with information to reduce the risk of hearing loss due to an antibiotic, reassure the parent that the child, if they had a variant identified, would have had an effective antibiotic still given to them, so they wouldn't have had lesser care, but that if they didn't want their child's information, not their personal identifiers, but just their information to be part of the study, then they could opt out of the actual study. And so that was the approach that we sought, and we went to the ethics committee asking, could we opt out, use an opt-out consent approach. So that was something that hadn't been done before, as far as we were aware, for a genetics study, but the ethics committee were comfortable with that approach, and they felt happy with us doing that. And it was fantastic that one of our patient representatives turned up to the ethics committee and explained why she thought it was important that the opt-out approach was appropriate. So the ethics committee were happy to grant consent to that, but the health regulatory authority contacted us just at the same time as we were being granted the ethical approval, and explained to us that they felt that we may be contravening and breaking the Human Tissue Act, which had been set out in 2004 to make sure that appropriate consent was in place for any testing of human tissue. So there were a number of issues when we went and looked at that legislation. One, which was most alarming to me, was that if I broke that law as the chief investigator, I could be potentially put in jail for 3 years, which didn't seem very appealing. And so we sought the advice of a number of different groups, and particularly Margot Brazier, who is a medico-legal expert in Manchester, and with her colleagues, with Nalan Thacker, who had led the clinical part of the Health Regulatory Authority and its interpretation of the Human Tissue Act, and an ethicist, a clinical geneticist from Southampton called Annika Lucassen. We wrote back to the HRA and set out our feelings that we felt that we were not contravening the Human Tissue Act, because this assay essentially, one, was dealing with DNA rather than human tissue, but also importantly was providing a diagnostic intervention that would alter clinical care, and was only looking for this one specific variant. We weren't looking at any other variants, and we wouldn't be doing any other form of genetic testing. So that all took some time to get approved, but eventually we got to the point where the approval was given. So essentially, you can see that we wanted to test the number of neonates who were successfully tested for the variant across the 2 sites. We had a number of secondary outcomes. The key thing was that we didn't want to disrupt normal clinical care. We wanted to make sure that you could introduce this test without disrupting what the nurses needed to do in all the other things they were doing to look after the baby. And we wanted to see what patients and staff thought about doing this genetic testing in the clinical setting. So one of the things we needed to do was to make sure that we had enough nurses all trained in how to use the assay, how to interpret it, and to feel confident with that. And so by the beginning of the study in January 2020, over 80% of all the Band 7 nurses, so every baby is assigned a Band 7 nurse, were trained, so we could always feel confident that there would be a nurse available to administer the test. So we started the study in January last year, both in Manchester and Liverpool, and that was just around the time that a number of things happened. So after using the test for a month, we had to pause because we had identified a couple of positive results, which when we checked them, they were false positives. And so we needed to do some investigation into why that was. And just around that time, of course, we were hit with the COVID pandemic. Fortunately, we were able to continue the study in Manchester because the COVID pandemic's not had a really significant effect on neonates. It's obviously had an effect on staffing levels on the unit, but the clinical team have been incredibly engaged and happy to continue. And then we had a further pause, which I'll update in August, which was related to some of the test results not working and a couple more false positives. So when we looked into these things, we've done a number of root cause analyses of why we were getting the problems with the testing. One we found was that the cartridge, when we put it into the machine, didn't quite fit as effectively as we wanted it to, and so some light would get into the machine, and that could potentially cause a problem. In the unit in Liverpool, when the tests were happening at night, it was occurring in one of the little side rooms, and when the nurses started the machine running, they'd then go off into another room to look after the baby. They'd come back about 20 minutes later. As they went into the room, the light automatically went on, and if the cartridge wasn't completely inserted, the light would get into the machine and then cause a false positive. We've had to update the software a couple of times, and the way that the machine links to the printer and to the Android machine has been challenging. And so we've at multiple stages kept going back and improving the assay to get that right. So the key things so far is that we've tested about 700 babies over the last number of months, and the vast majority of babies who have received antibiotics had undergone a test. So there were some that we missed because the testing just needed to be done, that the antibiotic needed to be just given so quickly, or because the result failed. We trained over 200 members of staff, which was absolutely fantastic, and the nursing staff have been incredibly engaged with the project. It's been truly fantastic. What we've seen in an interim analysis is that there's been no delay in the administration of antibiotics compared to what was happening prior to us starting the study. So babies have generally been getting their antibiotics within an hour. So you can introduce this genetic test without disrupting normal clinical practice. And the failure rate that we had for the test, which was about 15% at the beginning of the project, has dropped down to 7% with these improvements that we've introduced. So this is, hopefully this will work. This is one of our mums.
Really sorry, Bill, but we can't hear her.
Oh, okay. So let me stop and move on. I'm not sure why that's not shared. So this is just to explain. Sorry that you can't hear. So this is just one of our mums who had a baby on the neonatal unit, and she's just explaining how the nurses approached her, explained about the study, and the fact that she felt very positive that her baby had been given this option in terms of having the test, and felt that this was a valuable thing. And one of the things that we've been very keen to do is to undertake interviews and surveys of both parents and staff throughout the project to make sure that they felt engaged in the whole programme. So just to update, we are writing international guidelines through a program that was set up in America called the Clinical Pharmacogenetics Consortium, so that there will be international guidance about the use of genetic testing related to aminoglycosides and gentamicin, and which variants in this gene that we may need to consider, and how that information is used safely, and hopefully they'll be published next year. And so just to summarize, the study is due to complete in Manchester next Monday, the 30th of November. We will then have a period of analysis and hopefully able to publish our findings and update everybody early in 2021. We have achieved, I think, a number of things. One, to show that you can deliver a study like this, and you can have staff, parents engage with that it doesn't need to disrupt normal clinical practice, that the staff will use the information to change clinical practice. So far 2 babies have been identified who are known to carry the variant, and we have given them alternative antibiotics, and so we would suspect that they have not been put at high risk of hearing loss. And then we've performed clinical genetic counselling for the family to ensure that other at-risk family members are aware that they should avoid gentamicin and these antibiotics. So in conclusion, I think hopefully I've been able to show you that we've developed an assay that can provide a clinical relevant result in a clinically relevant time frame. That this is a point of care test that could potentially save up to 200 babies going through NICU every year, avoiding hearing loss, and that we can use it in normal clinical practice, and that if we can do this in the acute setting for newborn babies, I think we can apply it in other areas of medicine where you might need a genetic test result very quickly. I'd just like to thank all the people involved in the study. So Rachel, who I've mentioned, who's project manager, and John, who's my clinical fellow, who's done a fantastic amount of work, Ajit, who's the neonatal lead, and Nicola, who's the research neonatal lead in Manchester. Then large number of team members. Many thanks to Kevin Munro for the support from the BRC hearing loss and hearing health team in Manchester, and the patient representatives Rachel and Julia, who've been fantastic all the way through, completely engaged. The team at Gene Drive, who have developed the assay, and the team over in Liverpool who have worked with us to provide a different perspective. Thanks to our funders at NIHR and to the charities who have supported our work, and thank you for your attention.
Thank you so much, Bill. That's wow, so much information on a very early Monday morning. Given how you've concluded that next Monday is the end of your study, when do you think the rest of us would get to see this in our trusts? What's the kind of timeline for rollout?
Yeah, so that's a really good question. That's something that we've been thinking about right from the beginning of the study, about how you get through that next stage, how you get the test commissioned, and what that needs to happen. So do you need to go through NICE approval? What are the steps? So I sit on the clinical reference group for genetics, which oversees something called the Genomic Test Directory, which is about nationally commissioning all genetic testing in England. Not necessarily the UK, unfortunately, but Scotland, Wales and Northern Ireland are aligning themselves to some of this approach. So there's going to be a central commissioning of genetic testing, which is just coming into practice. We would hope to get this test approved through that pathway if the evidence all stacks up. The company are going to be bringing out sort of an updated version of their assay based on some of the learning and the things that's happened through the study. So as I said, when they tested it in their own laboratory space, everything has worked absolutely perfectly. And we know that when we use it in the clinic, things have required a little bit of adjustment. So we would hope that within the next year, we've been in a position to see that other trusts around the country would be able to implement this. We've had lots of interest from America, the Netherlands, Australia, Israel to try and get this implemented there as well.
And the other interesting point that people are asking about is how much does it cost per test?
Oh, right. So I don't exactly know. I didn't talk about, we are doing a health economics evaluation as part of the study, because the price hasn't been specifically set, but we estimate that it would be approximately about £50 per assay. And we've done an estimate that in England, if we were able to save 1 in 500 babies a year from experiencing hearing loss, that would result in a saving of about £7 million a year to the NHS through those babies not requiring cochlear implantation, all the follow-up, etc., that's associated with that. So that was a very sort of initial analysis, but we will be sort of doing a more formal health economic analysis as part of the final outcome of the study.
Lovely. And then just from Kevin, I think we can all echo that we're very glad that you didn't end up in prison.
I'm sure Kevin would have come to visit me.
You'd have the cake with the file for you. Just, is this something that will then just expand further, do you think? Will there be other genetic variants that it can be used for, or health conditions as a preventative measure? Is this just the beginning for you?
Yes, so that's a really good point. So in terms of our study, this M155H variant is the most common variant in the mitochondria that's associated with gentamicin hearing loss. From our analysis through the CPIC guidance and review of all the literature, we believe there are probably 2 other variants that aren't as common, but are probably important also. One of the things that I didn't mention in my my talk is that this variant seems to be equally prevalent throughout the world across different ethnicities. So as you know, some genetic variants are much more common in certain ethnic groups. This test seems very relevant across all ethnic groups. One of the things that we want to apply this technology to is certainly to stroke medicine. We've been doing some work developing an assay about antiplatelet therapy for stroke, and then also I'm particularly interested in pain relief and why some individuals coming through accident and emergency don't respond very well to their painkillers, and there's definitely a genetic basis to that. And if we could establish that very quickly, then people wouldn't get put onto the wrong analgesics, and I think that could be incredibly beneficial. So there are a couple of other non-hearing related examples that we're looking to try to develop this particular approach to.
Lovely, thank you. Well, we're coming to the end of our hour, so I just wanted to thank you again, Bill. It's been a fascinating start to our week, so thank you very much for everyone for joining us. As we mentioned, the webinar will be available on our website in the next couple of weeks for the next 12 months. Also, pop on over there to have a look at the posters that have been put in, and we have a couple more pre-recorded webinars amongst the abstracts there for you to find. So again, thanks very much, Bill. It's been brilliant. Thanks for sharing your time with us. And everyone else, hope
Pleasure.
afternoon.
Thank you very much. Okay, bye-bye.